All right. How is everybody? This is Aaron Rosari. I'm your professor for this course. Um, I must confess, it is a little awkward to speak just to a Zoom camera. I'm used to teaching in front of a live audience, having discussions more than giving lectures, but that's okay. We can mimic that to some degree in this online format. Hopefully you settled in to the coursework a little bit. We started off, of course, with a general introduction to the nature of ethical theory. So when we engage in ethical reasoning, what we're really trying to do there is find mutually acceptable ways of living together. The goal is to promote flourishing or goodness amongst the people in society together. Now, of course, society comes in many subcomponents. So, what constitutes flourishing and being fair and treating others with respect in one sphere of society might be somewhat different than in other spheres. So, for example, in the educational sphere, uh, what I owe to you all is just to be available, talk through specifically philosophical ideas regarding medical ethics. What you owe is lots of hard work and follow through. But the goal of medicine, of course, is a little different than the goal of education. When we're in a medical context, the healthcare practitioner, their goal is to serve the patient's needs given the resources available. And it is the hopefully the patient's role to think long and hard about their own values and decisions and what's in their control, what's out of their control. And the goal, of course, is to promote health, either mental or physical or both. Okay, now this week we did make a little bit of a move, at least in regards to that initial lecture, from discussing ethics generally speaking to discussing ethics more in a healthcare context. And, in that lecture, we listed different types of moral issues that can arise in the context of healthcare. These can deal with access conditions, who gets access to what treatments and why. A lot of that's financial, of course. Historically, unfortunately, a lot of racial and gender bias went into making those decisions as well. Hopefully, we're making some advances on that front. Um, there are also issues with end of life and beginning of life, ethical issues that were life and death issues, issues regarding privacy and different types of healthcare practitioner patient interaction. And as the semester goes on, we will touch upon a number of those issues from a variety of angles. You do have a main textbook, and most of what we'll use that for is okay, so this is a healthcare law and ethics course. We'll do a lot of the legal, a lot of the specific detail about just the way systems run, different professional concepts you might need to acquire in order to be effective in the healthcare context. That's what we'll use that textbook as a resource for. But in regards to the core ethical issues, I will be assigning a lot of text readings beyond the textbook. I'll be writing lectures and kind of talking to you in this format as well. Uh, Now, after you read this video, or listen to this video, you should go and track down in the modules folder the link to a discussion board question. And the point of that discussion board will be to reinforce this material. Okay, now Having said all of that, all I wish to accomplish in the rest of this video presentation is a discussion of the reading questions you are assigned this week in regards to the article entitled Autonomy's Temporary Triumph by a fairly influential and well-known bioethicist. You've probably never heard of him, that's okay. Robert M. Veatch. Okay, so the focus on this article is on the notion of autonomy. Uh, Next week, you'll get a set of reading questions in regards to chapters 1 and 2 of your textbook. And in chapter 2, there's 4 core values or principles that are listed. Autonomy is one of them. 3 others, I guess I could mention their names here, but you won't really know much about them until next week. Non-maleficence, which has to do with doing others no harm. Beneficence, which has to do with doing others good, promoting their health and flourishing. And justice, which has to do with a variety of fairness considerations. Those are the 4 core principles that our readings in ethics will be kind of structured around as this course moves forward. So this week, this will be one of 2 weeks where we will really camp out on the notion of patient autonomy. All right, so a person is acting autonomously in general when they have control over their own decision making. So if you were to look at the Greek, for example, the word auto means self, and nomi is kind of derived from nomos, which in Greek is a law. So a law or principle regulating behavior. So to be autonomous is to be a law unto oneself. So it's to take on the role of primary decision maker, at least in relation to decisions that affect you, and you become the primary decision maker, as opposed to, say, what has historically been the case in medicine, where the medical practitioner would be the primary decision maker. All right, so if you look at the first question from your reading questions, it says, read the first 5 paragraphs of Veatch's article on page 38. Veatch describes several medical issues that emerged in the 1970s due to advances in technology that led to the demand that patients be given a bigger role in medical decision making. And then questions A through D just kind of walks you through some of those specific issues that arose during that time period. So question A, and I'm sure you got these right. I'm just listing them here so I can say a little more. What group wanted to know more about the results of amniocentesis? Well, of course, that was women who are pregnant. Amniocentesis is an in utero test one can get, and it kind of reveals any developmental abnormalities or potential birth defects. And back in the 70s, back in the 60s, going back further, the assumption was that women would carry their child to term. Obviously, Roe v. Wade challenged that assumption. And doctors had a view of women as, it's weird since women carry and deliver children, they had a view of them as being in some sense weak, incapable of hearing bad news. So they took on a very, what's called paternal role in relation to their female patients, especially. Of course, this reflected a general gender bias I imagine is still with us to some degree, perhaps some considerable degree. So women stood up for themselves and they said, no, these are happenings in my body. I want to know about fetal development, how the child's doing, and their movements and protests won them the right to that information. And knowledge is power. So when women were able to access information regarding fetal health, that empowered them to make a lot of, to kind of internalize that locus of control and make decisions regarding their own and the in utero fetus's health. All right, moving on to the second issue, and 1B, what medical treatment did many want the right to refuse? All right, so this was might seem a little shocking to you now, but the answer is they wanted to refuse electroshock surgery, electroshock treatment, and even psychosurgery. Now, it turns out electroshock therapy, that's when electrodes, powerful electrodes, are hooked up to your brain and the brain is scrambled through a bunch of electricity. This is actually sometimes effective. People who suffer from severe depression will often experience considerable relief after getting these procedures done. Yet, if you think about it, it probably makes you squirm in your chair a little bit, the idea of having electricity sent through your brain. Uh, yeah, you wouldn't want doctors to have the authority to just foist that upon you, and neither did people back in the 70s. So that was another big movement that kind of decentralized control from the hands of the doctors and put it more into the hands of the patients. All right, 1C. What right did teenagers demand? Well, they wanted privacy in relation to obtaining birth control. And again, the attitude back then was not only does the medical establishment know best, but parents know best. So back in the day, teenagers didn't have that kind of unfettered access to birth control. And they gained that right more and more during the 70s and into the 80s. And of course, 1D, the terminally ill, they wanted the right to, basically the right to die. And at that time, that didn't so much involve introducing a poison or a toxin to kill the patient. We're going to do a unit on this later. That's called active euthanasia. What they wanted was the right to be left alone, to forego ongoing medical procedures, to unplug from life support. Of course, if you're on extreme life support, you're likely comatose, so it would be your parent, your family, um, either your partner if you're an adult or your parents or something like that, making that decision for you. But back then, the norm was to continue treatment until the body just kind of absolutely gave out. Uh, but that absolute commitment to the preservation of life at all costs, it's just not clear at all that this is the best way to go. And just strong arguments for allowing nature to take its course. Well, again, we'll have a unit on this. So that right was what was earned as well. Okay, now what these cases have in common is decision making is taken out of the doctor's hands and put more into the patient's hands. You might think, well, maybe the doctors and other medical practitioners, maybe they should have retained that control. After all, aren't they the experts on the various therapies and treatments being offered? And your discussion board question will allow you to explore this a little further. And the short response to that is it's one thing to be trained and be the expert on what a medical procedure is likely to accomplish, but it's another question whether or not that procedure ought to be undertaken. So if you were suffering from something like, let's say, cancer, and you had a choice, well, painful chemotherapy, an extension of life for several years, likely result, versus foregoing chemotherapy and maybe just focusing more on pain relief and kind of putting your life in order before you pass. Well, that's a value judgment. And doctors are not trained, especially trained in making value judgments, especially for other people. So when you look at the sorts of considerations that go into making medical decisions, not all of those have to do with the technical details of the likely outcomes of care. There's also a human dimension. What course kind of fits one's own set of values and what they need and want in the context of their broader life. So that's why autonomy replaced what is called paternalism. And this leads us to question two. In the sixth paragraph, Veatch defines paternalism. What is that definition? And I'm just going to peek just to make sure I get it word for word. The general concept's actually quite clear. So it's having the physician do what he or she thought was best for the patient. So it's referred in the article as Hippocratic paternalism. When we dive into the textbook next week, they actually have a copy of the Hippocratic Oath there, and you'll be able to read it for yourself and see the paternalistic nature of it. The idea was physician knows best in relation to medical issues. The physician's a lot like a parent, and they should make decisions for the patient. Now, 2B says, in your own words, how does paternalism compete with patient autonomy? Yeah, obviously you already had the opportunity to phrase this yourselves, but the basic idea is that it's a question about decision-making authority. Paternalism invests that authority in medical care practitioners, either doctors or nurses or psychiatrists, whereas bone and joint specialists, whereas autonomy places that decision-making more and more with the patient. It's not okay, so there is a trade-off between those two. So that's the basic answer to question 2B. And then question 2C says, before the 1970s, did any major statement of medical ethics or any regulatory document mention patient autonomy? And the answer is no, none of them did. So for literally hundreds of years, from the ancient world through the Middle Ages, through the Enlightenment, all the way up to the modern era, at least in Western mainstream medicine, there was no mention of this idea that the patient should take an active role in deciding the course of their care. All right, in the third paragraph, page of the third column of page 38, Veatch discusses how respect for patient autonomy is related to doing what one thinks is best for a patient. All right, so next week you'll get some more categories. When you're talking about doing what's good for the patient, that's called beneficence. And of course, autonomy is putting the locus of decision-making control in the patient's hands. People, and this is you, this is me, this is everyone, we often make bad bad decisions, irrational decisions. Hence the answer to 3A, which is, can respecting a patient's autonomy come into conflict with doing what one thinks is best for them? The answer is actually yes. So you might one day work in kind of like a mainstream hospital. You might get a patient who maybe has some superstitions surrounding anything from vaccinations to blood transfusions. to just not liking anything that's quote unquote unnatural. And they might opt for more alternative medicines, some of which are, they are known to be somewhat effective, others which are utterly untested, some are which are known to be kind of worthless. So you have to evaluate on a case by case basis, of course. But one might be, if one were a doctor, for example, you would often encounter a patient that wants to make a bad choice, even a bad choice relative to that patient's own goals. So the patient might actually really want to get better, but think that doing this in some sort of non-evidence tested way might be superior. So by respecting the patient's autonomy, which is nowadays what one must do, there is the potential for real conflict there with doing the patient the most good. All right, so 3B, which take precedence over what? Beneficence, doing what's best for the patients, or autonomy? And Veatch says, well, autonomy has to take precedence. And this, if you think about it, isn't a no-brainer, but it's what we all want. In the end, we want to be able to walk into a medical care facility. We want to get as much information about all the potential treatments as we can get and process and understand, but then we want to make the decision. Now, some people aren't like that. And those persons can turn that authority over to a doctor and say, hey, what would you have me do? But we would all like, the opportunity either to not do that and make the decision for ourselves, or just strictly go by with what a doctor says in a particular situation. Uh, and Veatch, he doesn't list his reasons per se, but his view is autonomy should be a higher value than beneficence. And I suspect, although I don't know, that you'll agree with them. That when you put yourself in other people's shoes, you wouldn't want your own autonomy robbed from you. So you probably wouldn't want to see other people's autonomy robbed from them. And I think as people growing up in American society and culturated the way we were, we hold this value pretty deeply. And it's for better and for worse, the deeper value than beneficence. All right. So 3C asks you to agree or disagree with each, and I'll be interested to read what you said. And of course, it's fine if you disagree with them. You might think benefiting the patient should come first. Uh, but yeah, but remember, doctors are not especially trained in value assessments. They're only trained in the efficacy or fruitfulness of various treatments. So I guess that would be one of the arguments favoring autonomy. All right. Now, there's more on that question sheet. There's an interesting aside on Karen Quinlan. You can track that through and read it. It's a fascinating story. And then Beach's article gets a little more technical pretty quickly. And it switches from discussing autonomy vis-a-vis paternalism and he starts talking more about social justice. And we may return to that portion of the article when we look at justice issues in healthcare a little more carefully. All right. So I hope you found this lecture useful. And email me with any questions. We can always do a one-on-one Zoom meeting. You can come to my office. That's all on the syllabus. Yeah, as much contact as you desire and want to kind of make sure you're getting all the understanding you need to move through the course well. Yeah, I'm here for you. I'm a full-time instructor here, so I have lots and lots of time to dedicate to students. So just reach out and I'll always be receptive to that. Otherwise, please proceed to the discussion board That's posted and will be due next Monday. And if you need an extra day or two on that assignment, that's okay. Um, yeah, so maybe I'll actually make it due next Wednesday. That might actually be better for y'all. Now that I'm thinking out loud. All right. So, all right, it was good talking to you, and look forward to interacting more in the future. All right, goodbye.